The most dangerous moment in your bedroom tonight is not the noise, it is the silence that follows it. The pause between snores when everything goes quiet. Because when the snoring stops, the breathing has stopped with it. The airway behind your tongue has sealed shut under a physics equation published in 1738, and your brainstem is counting the seconds until it overrides your sleep to force the airway back open. The noise is a vibration, the silence is a collapse. And the physics that governs both has never been explained to you. Your partner has been telling you for years, you snore. What they may not have told you because they may not have known is that the silences between the snores were the moments they should have been counting. When air flows through a tube and the tube narrows, the velocity of the air through the narrow section increases. Bernoulli's principle states that the increase in velocity produces a decrease in lateral pressure on the walls of the tube. The faster the flow, the lower the pressure pushing outward on the walls, the more the walls are drawn inward. The more the walls are drawn inward, the narrower the tube becomes. The narrower the tube, the faster the flow. The faster the flow, the lower the pressure. A self-reinforcing loop with two possible endpoints, oscillation or collapse. The tube is your pharynx, the space behind your tongue and soft palate, and it is the only segment of your entire airway that has no rigid structural support. The trachea is held open by cartilage rings. The nasal passages are supported by bone. The pharynx is supported by muscles, a group of dilator muscles that hold the airway open against the collapsing forces of negative pressure during every inhalation. During wakefulness, neural drive to these muscles maintains adequate tone and the airway stays open. During sleep, muscle tone decreases across all skeletal muscles, and the pharyngeal dilators lose 50 to 70% of their waking force. The airway that was 15 millimeters wide while you were awake narrows to 8 to 10 millimeters during sleep before any pathological factor is added. Sleep itself narrows the airway by reducing the muscle tone that holds it open. That is the starting condition. 4 independent factors narrow it further, each one a separate mechanism, all operating simultaneously in the space behind your tongue. Now age. Because the muscles that hold the airway open undergo the decline that every skeletal muscle in the body experiences. Pharyngeal dilators, the genioglossus that pulls the tongue forward, the tensor palatini that tightens the soft palate, undergo sarcopenic changes decade by decade, motor neuron loss, fiber atrophy, shifting from fast twitch to slow twitch. The genioglossus that held the tongue firmly forward at 30 generates less force at 55. The tensor palatini that kept the soft palate taut allows it to sag. Simultaneously, the pharyngeal soft tissue, the mucosa and submucosal connective tissue, becomes more compliant with age. Collagen cross-linking changes the tissue's elastic properties. It becomes floppier, more prone to vibration under the Bernoulli-driven pressure changes, more likely to collapse under the suction forces the airflow generates. Viewer who did not snore at 35 and snores at 55 has not developed a new condition. The muscles that held the airway open have weakened, the tissue that formed the walls has softened, and the airflow that produced silent breathing through a 15 millimeter airway now produces vibration through an 8 millimeter airway. Prevalence reflects the accumulation. Roughly 10% of 30-year-olds snore regularly, compared to 40 to 50% of 60-year-olds. The increase is not because older people develop a snoring disease. It is because the 4 narrowing mechanisms accumulate across decades until the Bernoulli threshold is crossed. Everyone's airway is narrowing with age. The snorers are the ones whose combination of muscle loss, tissue compliance, weight, and anatomy cross the threshold first. Nasal obstruction is a 5th narrowing mechanism that operates through a different pathway than the pharyngeal 4, and the pathway explains why a blocked nose produces throat-level snoring. When the nasal passages are obstructed from a deviated septum, allergic swelling, or the congestion of a cold, the sleeper switches to mouth breathing. The breathing discussion described the consequences of this switch. The jaw drops, the tongue falls backward, the pharyngeal space narrows. But nasal obstruction adds a second effect the breathing discussion did not reach. When the nose is blocked and the mouth opens, the negative pressure generated during inhalation increases. The respiratory muscles must work harder to draw air through the narrower oral pathway. The increased negative pressure inside the pharynx increases the Bernoulli suction force on the pharyngeal walls. The walls are drawn inward more aggressively. The threshold for vibration and collapse drops. If you snore only when congested during allergy season, after a cold, when the heating has dried the nasal mucosa, you are experiencing the nasal obstruction pathway. Blocked nose forces mouth breathing. Mouth breathing drops the jaw and increases the negative intraluminal pressure, and both effects narrow the pharynx past the Bernoulli threshold. Treating the nasal obstruction: saline irrigation, nasal steroid sprays for allergic swelling. A humidifier for dry air often eliminates the snoring because the nose reopens, the mouth closes, the jaw moves forward, and the pharyngeal space returns to the width that keeps the flow velocity below the critical threshold. Dry air dehydrates the pharyngeal mucosa, increasing the tissue's stiffness and its tendency to vibrate rather than flex smoothly under the Bernoulli pressure changes. Humid air maintains the mucosal hydration that keeps the tissue supple. The viewer who snores more in winter, when indoor heating reduces humidity to 15 or 20% and less in summer, may be observing the humidity effect on tissue vibration properties rather than any change in the four primary narrowing mechanisms. A bedroom humidifier maintaining 40 to 50% relative humidity reduces mucosal dehydration and may reduce snoring intensity in people whose tissue compliance is the marginal factor. Well, wait. Because the narrowing from inside is compounded by narrowing from outside. Parapharyngeal fat pads, deposits of adipose tissue, alongside the pharyngeal airway, compress the airway from the outside. These fat pads enlarge with weight gain and sit lateral to the pharyngeal wall, directly compressing the space the dilator muscles are trying to hold open. A 10-kilogram weight gain produces measurable narrowing of the pharyngeal airway, as Schwab and colleagues documented on MRI. The narrowing that age produced from inside, muscle weakness and tissue compliance; weight produces from outside through fat compression. The two mechanisms are additive. The 55-year-old who has gained 15 kilograms since age 35 has an airway narrowed from both directions simultaneously. Neck circumference correlates with snoring severity more strongly than body mass index because neck circumference directly reflects the volume of parapharyngeal fat compressing the airway, while body mass index reflects total body fat distribution. Someone with a moderate body mass index and a thick neck may snore severely, while someone with a higher body mass index and a thin neck may not. The fat that matters is the fat adjacent to the airway, not the fat on the abdomen. A tape measure around the neck is a better predictor of snoring severity than a scale. And then position, because gravity determines which direction the tongue falls during sleep. In the supine position lying on the back, gravity pulls the tongue posteriorly. The base of the tongue, attached to the mandible anteriorly and to the hyoid bone inferiorly, falls toward the posterior pharyngeal wall. The distance between the tongue base and the pharyngeal wall, the airspace that air must pass through, decreases. In the lateral position lying on the side, gravity pulls the tongue laterally rather than posteriorly. The posterior airspace is preserved. Nasal breathing maintains a forward jaw position that protects the pharyngeal space. Supine position removes that protection. Someone who snores loudly on their back may be completely silent on their side because the gravitational vector on the tongue has changed by 90 degrees. Positional snoring present in approximately 50 to 60% of all snorers. The variable is not the airway anatomy or the muscle tone or the weight, but the direction gravity pulls the tongue. The anatomy that produces severe snoring in supine position produces silent breathing in lateral position because Bernoulli's loop never initiates. The airway is wide enough on the side that the flow velocity never reaches the threshold for pressure-driven wall collapse. Now alcohol. Because this one is pharmacological rather than mechanical, alcohol is a central nervous system depressant that preferentially relaxes skeletal muscles, including the genioglossus, the primary tongue protruding muscle that holds the tongue forward and maintains the posterior airway space. The relaxation is dose-dependent and temporally specific, with peak muscle relaxation occurring 2 to 3 hours after consumption, typically placing it in the early sleep period. Someone who does not normally snore but snores after drinking has experienced selective pharmacological relaxation of the one muscle keeping their airway patent during sleep. The genioglossus goes offline, the tongue falls back, the airway narrows, and Bernoulli's loop initiates. The partner who knows their spouse had wine at dinner by the sound of the snoring is detecting the pharmacological effect of alcohol on the genioglossus through the acoustic signature of turbulent airflow in a narrowed pharynx. Timing matters for the practical application. Avoiding alcohol within 3 to 4 hours of sleep allows the genioglossus relaxation to resolve before sleep onset. The snoring that occurs after drinking at 9 and sleeping at 11 may not occur after drinking at 6 and sleeping at 11 because the pharmacological relaxation has partially resolved by bedtime. You now know what narrows the airway muscles weakening from inside, fat compressing from outside, gravity pulling the tongue backward, alcohol relaxing the one muscle holding the tongue forward. The question changes from what narrows the tube to what happens inside the narrowed tube when the physics takes over. Once the diameter drops below a critical threshold, approximately 8 to 10 millimeters, the airflow velocity through the constriction increases enough to trigger Bernoulli's pressure drop. The decreased lateral pressure draws the pharyngeal walls inward. The airway narrows further, the velocity increases, the pressure drops, and the walls are drawn in further. Each cycle of narrowing increases the velocity that produces more narrowing. At a moderate level, the walls do not collapse completely, they oscillate. The tissue vibrates between the slightly open and nearly closed states at a frequency determined by the tissue mass, compliance, and airflow velocity, typically 80 to 300 cycles per second. The frequency range determined by the physical properties of the vibrating tissue, the way a guitar string's frequency is determined by its mass, tension, and length. The vibration is the snore. At a severe level, the loop completes fully, the walls collapse and seal the airway. Airflow stops, an obstructive apnea event. Blood oxygen drops, while carbon dioxide rises. After 10 to 30 seconds, the brainstem detects the blood gas changes and triggers an arousal, a brief awakening that restores muscle tone, reopens the airway, and allows breathing to resume. The viewer gasps, repositions, and falls back to sleep, often without any conscious awareness that the event occurred. Arousal that terminates each apnea event produces a sympathetic surge, heart rate spikes, blood pressure spikes, stress hormones flood the system. In severe obstructive sleep apnea, this arousal surge cycle occurs 30 to 60 times per hour, 240 to 480 sympathetic spikes per night. Each spike raises blood pressure, stresses the endothelium, and releases inflammatory mediators. Intermittent hypoxia, the repeated drops in blood oxygen between apneas, produces its own damage. Reactive oxygen species generated during the reoxygenation phase damage endothelial cells, promote atherosclerosis, and drive systemic inflammation through oxidative stress pathways that parallel the damage. Cigarette smoking produces repeated cycles of oxygen deprivation and reoxygenation, generating free radicals that corrode the vascular lining. Untreated severe obstructive sleep apnea doubles the risk of myocardial infarction and stroke, independent of other risk factors, as Marin and colleagues documented in The Lancet. The snoring partner, whose loud breathing is dismissed as annoying, may be experiencing 30 to 60 airway collapses per hour, each producing a sympathetic surge and an oxidative hit to the cardiovascular system. The sound is annoying. The silence that follows the sound, the pause between snores, the moment when the noise stops and the breathing stops with it, that silence is more dangerous than the noise. That escalation from vibration to collapse, to sympathetic surge to cardiovascular damage, governed by an 18th century fluid dynamics equation operating in a 15 millimeter space behind the tongue, is the progression no one described to me during the decades I treated the sound as a nuisance rather than a warning. Interventions address different narrowing mechanisms, and matching the intervention to the mechanism determines whether it works. Position. Sleeping on the side eliminates the gravitational tongue fall. The tennis ball technique, taping a tennis ball to the back of a sleep shirt, physically prevents rolling onto the back during sleep. Crude but effective for positional snorers, addressing the gravitational mechanism specifically. Weight. A 10% reduction in body weight produces measurable reduction in parapharyngeal fat pad volume and measurable increase in pharyngeal airway diameter. Weight loss addresses the external compression mechanism. Pharyngeal exercises. A program of oropharyngeal exercises: tongue, soft palate, And pharyngeal muscle exercises performed daily for 3 months reduced snoring frequency by 36% and snoring intensity by 59%, as Gumarais and colleagues documented in the journal Chest. The exercises strengthen the dilator muscles that sleep-onset hypertonia weakens. The muscles maintain more residual tone during sleep, the airway stays wider, and Bernoulli's loop either does not initiate or initiates at lower severity. The gargle discussion described pharyngeal muscle activation that overlaps with this exercise program. The pharyngeal constrictors and soft palate elevators that gargling activates are part of the dilator group that maintains airway patency during sleep. Nasal breathing, closed mouth breathing keeps the jaw forward, the tongue against the palate, and the pharyngeal space open during sleep. Mouth breathing drops the jaw downward and allows the tongue to fall backward, a postural shift that narrows the pharyngeal space and increases the probability of the Bernoulli threshold being crossed. Mouth tape, a strip of surgical tape, holding the lips closed during sleep, maintains the nasal breathing pattern and the jaw forward position for people whose mouths fall open after sleep onset. Sedatives, antihistamines, and muscle relaxants produce pharmacological effects similar to alcohol, reducing the dilator muscle tone that maintains airway patency. The viewer whose snoring worsens after starting a new medication may be experiencing the pharmacological narrowing that alcohol produces through a different drug operating on those muscles. The connection is worth discussing with the prescribing physician. And then, when the snoring has crossed the line from vibration to collapse, because the transition is not always obvious to the snorer. Arousals that terminate apnea events are typically too brief for conscious recall. You do not remember waking 30 times per hour because each arousal lasted only seconds. The warning signs that snoring has escalated to apnea: excessive daytime sleepiness despite adequate time in bed, morning headaches from overnight carbon dioxide accumulation, and the bed partner's report of observed breathing pauses during sleep, the most reliable diagnostic indicator available without instrumentation. The partner who says you stopped breathing for 10 seconds and then gasped is describing an obstructive apnea event with clinical precision. Nocturia connection is specific. The sympathetic surges from the arousals stimulate atrial natriuretic peptide release, which increases urinary output. The viewer who wakes 2 or 3 times per night to urinate may be experiencing apnea-driven nocturia, the bladder filling, not because of fluid intake, but because the sympathetic surges are driving fluid excretion. A sleep study measures the number of apnea and hypopnea events per hour, the apnea-hypopnea index. Above 5 is diagnostic, above 15 is moderate, and above 30 is severe. The viewer who snores loudly, wakes unrefreshed, and sleeps next to a partner who reports witnessed breathing pauses should pursue a sleep study. The snoring is no longer noise, but the acoustic signature of an airway that is collapsing and a cardiovascular system that is accumulating damage with every collapse. CPAP, continuous positive airway pressure, is the standard treatment for moderate to severe obstructive sleep apnea, and the physics of how it works maps directly onto the Bernoulli explanation. CPAP delivers a continuous stream of pressurized air through a mask, maintaining positive pressure inside the pharynx that opposes the negative pressure of inhalation. The positive pressure acts as a pneumatic splint, holding the airway walls outward against the Bernoulli suction that would otherwise draw them inward. The loop cannot initiate because the lateral pressure never drops below the threshold for wall collapse. The physics is elegant, a pump that counteracts the pressure drop Bernoulli described by maintaining a positive baseline that the negative swings of inspiration cannot overcome. CPAP compliance is notoriously poor. Roughly 50% of prescribed users abandon the device within the first year. The mask is uncomfortable, the pressurized air is unfamiliar, and the hose restricts movement during sleep. The poor compliance is unfortunate because the device addresses the physics directly and completely. Every night the mask is worn, every apnea event is prevented, every sympathetic surge is avoided, every oxidative hit to the endothelium does not occur. The nights the mask is not worn, the physics resumes exactly where it left off. For mild to moderate snoring that has not progressed to apnea, mandibular advancement devices, dental appliances that hold the lower jaw forward during sleep address the positional mechanism at the anatomical level. The device pulls the mandible forward by 5 to 10 millimeters, which pulls the tongue base forward with it, increasing the posterior airspace that Bernoulli's loop requires to be narrow before initiating. The device converts an 8 millimeter airway into a 12 millimeter airway, keeping the flow velocity below the threshold where the pressure drop becomes self-reinforcing. Jaw anatomy determines the baseline airway dimensions that every other factor narrows from. Retrognathia, a jaw that is naturally set further back, produces a smaller baseline pharyngeal space. Someone with retrognathia starts with a narrower tube before age, weight, position, and alcohol contribute their narrowing. This explains why some lean, young, non-drinking individuals snore. The baseline anatomy is narrow enough that normal sleep-onset muscle relaxation crosses the Bernoulli threshold without any additional narrowing factor. The anatomy was the single sufficient cause. The other four factors are additive causes that bring normal anatomy across the threshold. Bed partner deserves their own paragraph because the partner's sleep is being damaged by a mechanism the snorer cannot hear. Snoring produces acoustic energy in the 60 to 90 decibel range, equivalent to a vacuum cleaner or a busy road. The partner sleeping beside a severe snorer is exposed to this acoustic level for hours, producing repeated arousals from deep sleep that fragment the partner's sleep architecture without the partner necessarily waking fully. The partner accumulates sleep debt, daytime fatigue, and cardiovascular stress from the acoustic exposure, not from their own airway, but from the snorer's airway operating. Bernoulli's loop 2 feet from their ear. The relationship strain from snoring separate bedrooms, resentment, unresolved frustration has a physiological basis. The partner is genuinely sleep deprived, and the deprivation is caused by the fluid dynamics operating in someone else's throat. Women are underdiagnosed for obstructive sleep apnea by a factor of approximately 2 to 3. The condition is often framed as a male problem because men snore more loudly and at higher rates, but women's snoring tends to be quieter. The apnea events tend to be concentrated in REM sleep rather than distributed across all stages, and the symptom presentation is more likely to emphasize fatigue, insomnia, and mood disturbance rather than loud snoring and witnessed apneas. The diagnostic criteria were developed primarily from male patients, and the stereotypical presentation, loud snoring, witnessed apneas, excessive daytime sleepiness, describes the male pattern more accurately than the female one. The woman who reports persistent fatigue, fragmented sleep, and morning headaches without loud snoring may be experiencing REM-predominant obstructive sleep apnea that a standard screening question about snoring loudly would miss. Sleep stages affect the severity because muscle tone varies across the night. REM sleep, the stage characterized by dreaming and rapid eye movements, produces the most complete muscle relaxation of any sleep stage. The pharyngeal dilators are at their weakest during REM. The airway is at its narrowest. The Bernoulli loop is most likely to complete to full collapse during REM, which is concentrated in the second half of the night. The snorer whose partner reports that the snoring gets worse toward morning is observing the increased REM proportion in the later sleep cycles, compounding the muscle relaxation that drives the collapse. There is an intervention that sounds implausible but has documented evidence, and the evidence connects directly to the pharyngeal dilator muscles the physics identifies as the collapsible element. Singing. Regular singing practice, particularly exercises that involve sustained vowel sounds, pharyngeal resonance, and soft palate elevation, strengthens the dilator muscles through a mechanism identical to the oropharyngeal exercise program Guimarães documented. Clinical observation of regular singing practice has documented reduced snoring frequency and severity after 3 months. The improvement correlating with vocal exercises that specifically activate the tensor palatini and pharyngeal constrictor muscles. The singing works not through any acoustic property but through the muscular training the sustained vocal production demands. The dilators are stronger. The residual tone during sleep is higher. The airway stays wider. Didgeridoo playing, which requires sustained circular breathing, with the pharyngeal muscles maintaining an open, resonant airway for extended periods, produced measurable reductions in apnea severity, as Pouhan and colleagues demonstrated in a randomized controlled trial published in the British Medical Journal. The instrument requires exactly the muscular endurance in the pharyngeal dilators that sleep-onset hypotonia depletes. The playing trains the muscles. The muscles retain more tone during sleep. The loop cannot initiate as readily. Acoustic signature of snoring changes as severity progresses, and the changes are detectable by the bed partner long before a sleep study is performed. Early snoring is a steady vibratory sound, a constant frequency hum produced by tissue oscillating at a stable rate, indicating a narrowed but stable airway. Progressive snoring develops irregular amplitude, the sound crescendos and decrescendos as the airway oscillates between narrower and wider states, the tissue fluttering rather than vibrating steadily. Severe snoring develops pauses, the sound stops for seconds at a time as the airway collapses fully, then resumes with a gasp or snort as the arousal reopens it. The progression from steady to irregular to interrupted is the acoustic signature of the Bernoulli loop approaching its completion threshold. Partner who reports the snoring changed, it used to be steady and now it stops and starts, is describing the transition from vibration to collapse in terms a sleep physician would recognize immediately as a clinical escalation. The loop Bernoulli described is operating inside your throat tonight. 4 mechanisms: narrowing the 2 muscles, weakening, fat compressing, gravity pulling the tongue backward, alcohol relaxing the 1 muscle holding it forward. And the silence that follows the sound, the pause between snores when the noise stops and the breathing stops with it, is the loop completing. The airway sealed, the oxygen dropping, the brainstem counting the seconds until it overrides sleep to save your life. After years of hearing it described as a nuisance, the equation governing the sound was published in 1738 by Bernoulli, and the cardiovascular damage it produces was accumulating every night. The silence between snores went unheard.